We're recording now. All right, where would you leave? Okay, so we know the risk factors again. So risk factors are listed here, beginning here from ethnicity. So that would also include migrants. All right, migrants from, we have here already Asia. So Asia would be India, China, Philippines, Singapore, Indonesia, Malaysia, Thailand, or else, Korea, Japan. All right, so those are Asian countries, and the Caribbeans also. Right, the Caribbean, Jamaica, yeah, Haiti. Yeah, but you still have TB, right? No, Asia. I mean, Asia. ASIAN, right? Yes, just Asia. Like you. Yeah. A combination of them, but interrelations, so most of us are black. Huh? Wait, what? I don't understand. He didn't stay together. I don't know. You said like the Caribbean is Asian. No, he went to Caribbean. I don't know what's going on. What's happening? No, I thought he was listing the country that's Asian. No. So are we clear with? Okay, all right, okay. And incarcerated people, homeless population. You can also add there IV drug users, because when they're impaired, do they necessarily make the best decisions? No, they're like living like a homeless person, right? So they don't take care of themselves. So they fall under the same category. Okay, so they are also at risk. I'm not saying TB is transmitted by IV drug use. Okay, it's really the behavior of the IV drug users that puts them at risk for TB. All right, and as far as migrants go, let's say regardless if it's Hispanic or Asians like myself, or other ethnic minorities, the immigration must be within the last 5 years. Okay, so meaning you have to be a recent immigrant. Is that clear? Meaning not all immigrants, because I've been, let's say here, I don't know, 20 years. So I'm not a risk to you anymore, because in fact, how I got my latent TB was here, because I was negative. I mean, although we are, it's endemic in Asia, the TB is endemic, we still get tested. I mean, we work in the hospital, we still get testing. I was negative all throughout. The second year that I was here, I turned positive. So you can say what, the first thing in my mind was, I don't believe this. I grew up in a country where TB is everywhere. I never got sick. I come here and then I get TB. All right, here are the 4 classifications. So latent is what, I'll be your good example. So I was exposed, I had positive for TB. It's not true that, I should say it's not always true that you'll turn positive for PPD, you'll test positive for PPD because of BCG vaccine, because all of us are given the BCG vaccine within our first 30 days of life. That doesn't provide lifetime immunity. The immunity does wane over time, especially after 10 years since you received it. We give BCG vaccines here, but not to newborns. We give them to high-risk people. So let's say you're a nurse, you're traveling to a country where TB is prevalent, then you'll be given a BCG, right? It's only given to select populations, usually healthcare workers, or let's say you work for the United Nations, or you're a diplomat, for instance. Okay, so before you travel to a TB endemic area, you'll be given a BCG vaccine. But anyway, back here, so it's not true that because you were given a BCG that you'll be positive for PPD forever. No, the immunity is not lifelong. There's evidence already. You ask WHO, or countries like myself, you ask the doctors there. No, it doesn't provide lifelong immunity. Oh, if it's been over 10 years, you can still get TB, right? Primary tuberculosis infection, this is now the active TB infection, meaning you have the exposure, then you're sick. With primary progressive, this is now a more severe form of the infection. And then we have drug resistant, of course, will require more than just the 4-drug regimen, which is standard. So here's latent TB. You have the bacteria somewhere in your lungs. It's not making you sick because either your immune system is really good or they're just not growing enough yet. They will have the chance later when your immune system is lowered. So that's why they're also called opportunistic infections. That's why they're affecting or infecting HIV or AIDS patients, because they are exactly opportunistic infections. So they remain dormant in latent TB. No symptoms, or if anything, nothing at all. So therefore, not contagious. They don't have the capacity to pass on the bacteria. Again, it will remain dormant, but you're still infected. So why not just treat it, get it over with, so you don't have to worry about it later? But you're not really forced, because since, again, you're not contagious, you don't have to take the treatment. Here's primary, I already mentioned TB, primary TB. Again, unless the patient is infectious, symptomatic, they cannot pass on the infection. And here's our main problem, which is a focus for today, will be the symptomatic population. So they are sick and they are very infectious. Symptoms include fatigue, nothing really specific. So fatigue, weight loss, night sweats. So a sick person, somebody who's infected, and they have this cough that doesn't um, die off, right? They'll have a cough for over a month, does not wane, and they have this sputum, either blood streaked or rusty colored. This one's quite rare. Usually people who do not finish the treatment go on to develop a multi-drug resistant strain. Diagnosis. So how do we make a diagnosis? We have several ways. The most common is the PPD. So this is the MAN2 test, or the PPD skin test. We inject 0.1 ml intradermally, and it is read at 48 and again at 72 hours after injection. We will be looking for an induration. So I'll go back here. Let's go to 24.7. Is this chapter 24? Where is that? Let's see. 472. Let's see. Yeah. 474. How come I didn't see it?
It's all the way under teaching.
What page again?
474.
Did I pass it? Okay, here. So as far as interpreting a skin test, we put people into 3 categories. Remember the risk factors I mentioned earlier? So since they are the people that get infected, then we put them into groups. So first group will be considered positive skin tests if they have a 5 millimeter minimum or greater. It has to be in induration though, not redness, not swelling. Okay, it has to be induration. How much is it raised by? So if we have 5 millimeters or more, it's positive in these populations right here. HIV or people living with somebody who's infected or immunosuppressed for whatever reason, maybe an adrenal disorder or autoimmune disorder, they're pretty much taking steroids, or after solid organ transplant, for instance. And they have if it's considered positive at 10 millimeters or greater, if you belong in these people right here. So you live or work in these high-risk settings, namely, again, prisons, homeless shelters, mental health facilities, long-term care, etc. Here's IV drug users. And then the recent immigration again is within the last 5 years. And everybody else who don't belong in the 5 millimeter or don't belong in the 10 millimeter group, the rest of the population require 15 or more to be positive. So where do you guys belong? Miss Miss Ben, where do you belong? Are you in the 5, 10, or 15?
Hold on.
Where?
Sorry, I got lost. Sorry.
Or anybody, you guys tell me where you belong, each of you.
10.
Okay, people say 10. Well, 10. Any 15s here? Or 5s? I'm HIV positive, by the way.
Yeah.
Any 15s? 5s? Okay, truth is, there's nobody who's a 15 here, all right? We're nursing school. We go to clinical. We used to be 15 before nursing school, but not anymore. Okay, we're not. Uh, yeah, we're not 15s anymore. Okay, let's go back up here. All right, so tests, we have more tests. We have blood-based tests instead of the skin test. We have IGRA. Most popular is the quantiferon gold, because that's just a blood test. We have a TB, T-spot or TB test. Regardless of the test though, whether it's PPD, IGRA, quantiferon gold, or T-spot, none of them confirm TB. All they do is indicate exposure to TB. Again, none of these tests confirm that you have a TB diagnosis. What do they do only? Confirm exposure to TB. Yes. Sorry? Yeah, you're referring to this one, IGRA. Yeah, but again, none of them confirm a TB diagnosis. They only indicate that you've been exposed to TB. Yes. Right. The only way we'll know is based on your symptoms. And if you have symptoms, we have to get a sputum culture. Then we can determine that you are TB positive. Okay, only a sputum culture. An X-ray can also make a diagnosis. As far as X-ray goes, it will only indicate whether or not there are fibrotic changes in your lung. Let's say there's a spot there, meaning you had an infection, indicating an old lesion, but we can't tell though whether that lesion is new or is old. All right. So unless you are really symptomatic, then we can make a diagnosis that okay, you have active either primary TB or primary progressive TB. If you have no symptoms and you're positive in any of these tests, then you have latent TB. All right. Now, as far as BCG, um, here, can somebody read this, please, Mr. Chen?
Individual who receive Bcg immunization may show false positive PPD, one not infected with TB.
All right.
Vector.
Right. This is though, I want to make sure that this BCG vaccine must have been given in the last 10 years. If it's been beyond 10 years, or let's say you want to make sure a quantiferon gold test is not affected by BCG. Does that make sense? Meaning if you receive a BCG and you want to make sure, am I really, and your PPD is positive, am I really, was I really exposed, or is this a false positive because of my BCG? Then you go to a quantiferon test. Quantiferon gold is not affected by the BCG. All right. So it can rule out a false positive test.
Question.
But again, yes, sir.
I have I have this BCG when I guess when I was child,
Yes.
but always if I do the skin test, it's always bigger than 5 millimeters. So it's always getting either chest ray or blood test.
Uh, yeah, but do you reach 10 though? Or only 5?
Way past that.
Way past what, 10?
Yes, way past 10 years. I've been here for like over 20 years.
Okay, so way more than 10 millimeters and you have no symptoms, right?
Oh no, I mean yes. No, I saw you talking about yes. So yes, it's past 5 millimeter, but not 10 millimeter.
Okay, then that's a negative. You have to be 10 in order to be positive. I mean, considering your profile.
Most of us on channel country have it.
Well, again, I'm just going by what the textbook says. I'm not a doctor. However,
So I'm not saying
if
they
it
have to
is,
be the BCG.
yeah, again, that doesn't provide lifetime immunity. So if you really want to be sure, get a let's say quantiferon gold, and if it's negative, then that the PPD you had is a false positive. Any other question on testing? All right. So treatment. We have 4 drug therapy, which is not mentioned here. Well, it is. We have table 24.8. Okay, before we go to table 24.8, let's look at precautions. So the minute we receive an order for airborne precautions, what do we do?
Isolation.
All right, put the patient in a negative airflow room. All people there must be wearing an N95 mask, and of course an N95 mask is fit tested, meaning you can't just grab one without being fit tested. By the way, do you guys know the size? Because you were all fit tested, right?
Not here.
No?
At work, not in school.
Oh, I thought you were.
No, we weren't. That one is always going to go.
Okay, anyway, yeah, so since you were not all fit tested, then you can't be in a negative pressure room. You can't take care of TB patients if you go to clinical, right? Because we don't know what your actual size is. So for your own safety, no TB patients for you. Who else are on airborne precautions besides TB?
Measles.
Measles. Who else? Chickenpox.
And
Meningitis.
COVID now.
Yeah, meningitis. Is it definite for COVID?
Yes.
You put them on negative pressure rooms?
Yes.
Do you have enough negative pressure rooms for all the COVID patients?
There's zoning them now. Because most ICUs are enclosed doors.
Okay, all right. Okay, so for all other people though, because you do have visitors or this patient will eventually leave the room in order to go for testing, they have to, since they're not fit tested, you will put a snug fitting surgical mask. Okay, so add snug fitting here. All right, this is safe enough, but they definitely can't go maskless out of the room. Complications, of course, is lung injury, and that can lead to ARDS and all sorts. Anyway, the end result is death. All right. Let's go to treatment, 20 table 24.8. All right. This is only the for exam questions because TB is in the NCLEX. You'll have to go use your drug book. Whatever, no, not whatever. Whatever was prescribed to you, the nursing drug handbook that you're using, that's what I'm using for the test. Okay, so I have specific questions on nursing responsibilities for each of these drugs. So INH, Refam, pyrazinamide, and ethambutol. All four will be, the questions will be taken from your drug handbook.
What do you have there, Professor? But it doesn't say get one.
What?
It just said get one. It just said get one.
Doesn't really matter. As long as it's a nursing drug handbook, they have exactly the same information. They have the same precautions. Let's say you teach all of these patients to avoid alcohol. Ethambutol has a, for example, serious side effect of optic neuritis. It will cause visual changes, possibly color blindness, or if not, blindness. One of them causes a reddish orange discoloration of the urine. Um, all of them except ethambutol are nephrotoxic, meaning so therefore you can't. However, in the case of ethambutol, if you do drink alcohol with it, you will have violent nausea vomiting, and I mean like you'll wish you never do that again. Okay, that
I'm
kind
sorry, we
of
don't see the screen.
severe. I'm sorry.
We do not see your computer screen anymore.
Not at all.
No, you kind of cut off.
I'm here on page 473. Again,
Now
what
we
I'm
do.
talking about is not in your textbook. You'll have to use a nursing drug handbook to answer questions on nursing responsibilities for INH, rifampin, pyrazinamide, and ethambutol.
You said something about nephrotoxic, so they're definitely not.
No, I said I meant hepatotoxic, the liver. Okay. Again, I don't have it here, but every nursing drug handbook will say the same thing. Right? They'll have the same nursing responsibilities for TB drugs, and these are the standard 4-drug regimen. Unless, of course, if you have latent TB, then you'll only be on the first two. You'll only be on INH and Refam for about 6 months. If you have active TB, it's a minimum 12 months or longer for drug therapy. All right, let me explain how it is. because it's not easy. Imagine no alcohol for 6 to 12 months. Is that easy? And who are these people that get TB? Who are they again? Yeah, try
Drug
telling a
abuser.
homeless person no alcohol for 6 to 12 months. All right, or an IV drug user. You know what I mean, right? Okay, the profile here, we're not talking about, most regular people. Okay, so some of these patients are homeless, IV drug users, etc. So you have to tell them, you have to explain how exactly is this taken. All right, let's look at we'll only look at the first row. Okay, I'm not teaching all three, because most of the patients we see are newly diagnosed TB patients. Okay, so this is the standard treatment, this one, row 1. Okay, so new infection, new culture positive. All right, so for INH and ReFam, as you'll see, it's 2 months. Daily times 2 months. So and then PZA 2 months, ethambutol 2 months. They're all 2 months. So for the first 2 months, how many drugs are you taking? This one's 2 months, 2 months, 2 months, 2 months. So how many drugs are you taking for the first 2 months? 4 drugs. Now that is the intensive phase. Okay, intensive phase, like intensive care. Intensive phase is 2 months, 4 drugs. On the continuing phase, for another 4 months, how many drugs? 4 months? 4 months? So, how many drugs for 4 months? 2 drugs. Now, does that sound better? Yeah, that's better than if you ask me. So you have to explain it to your patient, that way they understand, no, it's not really 4 drugs for 6 months or 12 months, right? So it's yeah, for the first 2 months, yes, you'll be taking 4, but then after 2 months you'll be down to 2, right? So that's a treatment, if it makes any difference. Okay, but yeah, psychologically, yeah, I'm only down to 2, instead of the 4. That sounds better. There has to be evaluation. We have to know that the drug worked, the treatment worked. So since this is a active TB, how did we know that they had active TB again? Okay, so we got a sputum sample and it tested positive. So right here, we have a sputum culture and that was positive. That's why we started a 4-drug regimen, standard for new infections. 4 drugs for the first 2 months, 2 drugs for another 4 months. You did drug therapy. All right, and then again, you're responsible for the drug handbook, okay, for nursing teaching and nursing responsibilities for those 4 drugs. Forgetting something. All right. These people, are they isolated forever? Are they isolated for the whole 2, 4, or 6 months? No.
No.
Not necessary. So isolation will have to be done only for about 2 weeks, because if they take the drugs non-stop for at least 2 to 4 weeks, minimum 2 weeks, and then there has to be improvement in symptoms, meaning if their symptoms improve, doesn't mean symptoms are gone. Okay, just symptom improvement after 2 weeks, they are no longer contagious. All right, they can go out. Does that mean they have to be in the hospital for 2 weeks? No, not necessary. I mean, they can go home. You may say, oh, what about the family? Well, chances are they've been living with that family even before they got diagnosed. So has the family been exposed? 100% yes. So all we'll do is test the family members.
What test do they do, Professor?
What?
What test do they
Same test we did for this patient. Yeah. No, not the sputum. We do the PPD or quantiferin, whichever is applicable. All right. So that's all we do. We test the family members because likely they've been exposed too, okay, because they live in the same house. So they can go home. It's okay to go home. So they quarantine for 2 weeks as long as they take the drug therapy religiously every day for 2 weeks. After that, and then there has to be two. They've taken it for at least 2 weeks and they have they have symptom improvement. They're no longer infectious. However, does that mean they can stop the therapy? They stop, then we'll have to start over and probably with more drugs this time because now we've developed a multi-drug resistant strain. So all of these must be taught to the patient. You explain to them why we're doing the treatment, for how long, and what are the possible consequences for non-compliance. Now, let's say your patient is from the South or Middle America. Those who have, big American flags on their property, you know what I'm saying? Like they say, oh, this is America. You can't force me to do anything. Well, if you have TB, yes, we can, because this is a public health concern, right? You're infectious, so you can't go around infecting other people. You have to be treated. But I say, well, this is America, right? Well, the Department of Health does have police power, so we can detain you involuntarily. Hey, there are laws on that. I mean, yeah, that's one exclusive. Just like just like how the military can quarantine an entire city or an entire province, for instance, or an entire country. Okay, so the military can do that. That's part of they can be tapped by the Department of Health if if a public health emergency arises, right? So yes, there is so your rights can be temporarily, yeah, taken, right? So you have no freedom of travel and all that, right? The alternative is really, you'll be committed involuntarily in an institution. Most people, I mean, see it, they'll just, for the heck of it, they argue, but then they'll see, what am I doing? This is going nowhere. So they'll settle for treatment. All right, get it over with, and then everything's good. So they have to be tracked. Like myself, every TB positive patient is tracked. You can be treated by the government. I was under the health department. Um, but any patient can be under a private practitioner, but still that private practitioner must report to the Department of Health, meaning there's no case of TB, no known case of TB that is not tracked by the DOH, right? It's serious, so you have to be tracked to see, did this person complete treatment? Okay, did we get a follow-up evaluation? Is it really cured? Okay, all right. So, and then you're off the list. So what if we really have homeless people, okay, who, I mean, they don't have insurance, they don't have a pharmacy. So how do we ensure that they're really taking the pills?
public health nurses?
Okay, we put them under what's called DOT. That's not Department of Transportation. That's direct observed therapy. So unlike you and me, wherein you'll be given a pill bottle, 30-day supply, here it is, and then you'll get another one filled by a pharmacy, you'll pick it up on the next month. So they'll be literally taking the pill, won't be given the pill in a bottle. They'll be given it in a cup. They'll have to go to a treatment center, either a doctor's office or a health department, to take the pills every day. They'll say, well, what do? I don't have no money for transportation. No, we have budgets for these. They will be given Metro cards, whatever, a cab voucher, whatever. They'll be given the resources to, okay, come here, here. They'll be even given a meal allowance, for their trouble, for coming there. Yeah, here's the meal for the day. Yeah, additional incentive, for them to get their pills. So they'll do that for the entire 6 or 12 months. Yes, taxes pay for these. Or would you rather them go out infecting you? Yeah, they are. Yeah, it's under the, we have budgets for these. And you would be happy, your taxes are going to, for some good. You'll benefit from this. You'll be thankful that they're not infecting people. All right. So that's here. Direct observed therapy. Um, they're managed differently by every state, depending on the patient population. So they make variations just to ensure compliance. But the key here is they're monitored, they're supervised during the treatment. We ensure compliance. Um, Again, if we have a patient who's really non-compliant, they will be committed for the entire duration of the treatment, and then they can't leave the facility because of that reason. And then after that, after the treatment, then they can go. Right. Right. In some cases, though, as stated here, the isolation at home, the quarantine at home, maybe up to 6 weeks, really depending on their response. So after 2 weeks, they have no symptom improvement. Can we let them go after 2 weeks? Of course not. So it depends. If they after 2 weeks no improvement, then they continue staying at home, right? But the minimum, usually most people have improvement about 2 weeks. Last thing is, when can you go back to work? Well, your employer is going to require a negative sputum culture, and your doctor won't give you a okay to return to work unless you get 3 negative sputum cultures, and each sputum culture is taken usually 2 weeks apart. So yes, about 6 weeks you'll be out of work. Is that understood? So if you have active TB, so you'll be out of work for 6 weeks. Because that's how long it takes to get 3 negative sputum cultures. Or you may have a setback if, let's say, you don't get a negative sputum culture, which is rare. Um, Treatment is, as long as you again comply every day. Um, I've never encountered a um, complication related to treatment. Okay. Any question on TB? So we did see cystic fibrosis, we did COPD, we did we didn't do ABGs yet? Okay, let's do ABGs. Is it on the blueprint? Okay, we completed that. Let's look at your